I've never given this talk before, and for this audience and watching people walking around last year and seeing different things, I said, well, I'm not going to give one of my academic talks about CRPS, which I give to doctors and occasionally give to patients, and mainly give to doctors to help them understand CRPS, especially like orthopedists who, although they see it quite a bit, and podiatrists see it quite a bit, they don't understand it, they don't know how to make a diagnosis. And what really truly is the most important is that they often don't refer it early enough. Because if you refer CRPS in the first month or two, you have a chance of a complete remission. You have a much better chance that it stays away. So this talk is meant for you guys out there. And by the way, how many of you actually have CRPS? Ooh. And how many are you are caregivers for people with CRPS? Okay, so that pretty much makes it. Are caregivers. There's a lavalier here. Where's the little, is there a mic that goes to this? No, okay. I don't know how loud the mic is. I mean, now I'm really yelling into it. I don't like to be tethered to a microphone. Usually I have one where I can walk around a little bit, but I will do my best. Okay, so now it's good to see that pretty much everybody in here is either a CRPS warrior or a caregiver. And one of the things that I always tell my patients, there are three main ingredients for success in CRPS. Number one, patient's motivation. Number two, having a good support system, and thank you all for being caregivers for your CRPS loved ones. And the third one is to have a doctor that really knows what they're doing, which unfortunately in many of the cases does not occur. So what the purpose of today's talk is to give you some tidbits of little things that I think are important. And I heard Dr. Sadiq speak today, and a lot of what he was saying actually fits in. A few of his catchphrases are very important and fit in here. So the topics, okay, the name of my facility is the Center for Rehabilitation of Pain Syndromes. And notice we don't have the word cure in our name, because you don't cure CRPS. You can get it at best into remission, but you want to rehabilitate patients. You want to be rehabilitated not only to make the pain get less, which is my secondary goal. My first goal is to have you have a normal life again, and that's what the rehabilitation is about. And there are many things that we do to minimize pain, but if we don't do the rehabilitation that comes along with it, we do not succeed. So I'm covering a bunch of random topics today that I think have relevance to CRPS patients, and some of you may not like everything I have to say here, and I apologize for that. But I think these things are important. And so we're going to cover assistive devices, which are basically casts, crutches, and wheelchairs. Then we're going to talk about surgery and childbirth. Then we'll talk about what happens to you if, let's say, you have CRPS and you're in remission, or even if you're not in remission and you suffer a physical trauma. Then a topic that I've never heard anybody talk about, which is flying and altitude and its effect on CRPS. So I'll talk to you a little bit about that. And finally, overlapping some of what Dr. Sadiq was talking about, I'm going to talk about choosing a practitioner, maybe a slightly different angle than what he was saying. And also, I know a lot of people, just in walking around this morning, people are asking me about ketamine. I'm not talking about ketamine today, but one of the topics that I want to cover in choosing a practitioner is also, if you're deciding that ketamine is what you want to see if it'll be good for you, how do you pick somebody to do that? And I think that's a really important one. So let's dig into it. Assisted devices. First, casts. Well, Dr. Sadiq said something really important. The name of the disease in CRPS is use it or lose it. And if you baby your limb, if you cover it and keep it from getting any sensation, if you keep it from moving, you are likely to have it get worse. And in fact, one of the causes of CRPS is immobilization. Not having CRPS and being put in a cast, some people develop CRPS just by being immobilized. So I went on the internet and I got a picture of this one, and I don't know if you can see, but over here, this thing separates. And it has Velcro that holds it together. So the cast is put on, and this kind of cast is really good for a CRPS patient. It's a splittable cast with Velcro to hold it together. So you certainly, if you have a fracture in your foot or your leg, you don't want to be walking on it, but while you're lying there and nothing is displaced, you can touch it. If you open the cast, it can be exposed to different temperatures, and it's getting some stimulation that helps either prevent CRPS or prevent it from advancing. And so try not to stay in a hard fixed cast, and if your doctor wants to, your orthopedist wants to put you in one, tell them that they do make split casts, and I'll be really careful while I'm lying in bed. I'm not going to bear weight when I'm not in the cast, but I need stimulation of my leg or my arm. Now, this is a topic that's near and dear to me, and it's called crutches. Now, last night, I actually saw people using crutches that I think were good crutches, but I also saw somebody that had these. Never have these. What's wrong with this? At your armpit is something that can irritate the nerves that come out of your armpit and go down your arm. We call it the axilla. Hard crutches cause CRPS in the arm of somebody who had it in the leg. And I cannot tell you, in my close to 3 decades of treating CRPS, how many people I've come in who originally had a leg problem, then wound up in an arm because they were using this kind of crutch. So I went on the internet so I could show you the right kind of crutch to get, and I don't own any stock in this company. This is called a Moba crutch, and you can get it on Amazon. And there are 3 features of this crutch that I think are really important, and I'm going to show you. I blew them up. This is the most important part. You see, what goes in your armpit is suspended and soft, and so if you put weight on it, it distributes it evenly, so there's never any pressure on nerves. The next part is the handle here, which once again allows you to take some weight off your armpit, so you're doing it on your arm. And finally, there's special cushioning down at the bottom. So what I say to you, all of you, is that I think crutches when you have CRPS is a bad idea, and I see a lot of people with these 4-legged walkers that I'm going to talk about. Even if you're 18 or 21 and you don't want to look like you're an old person by going around with a 4-legged walker, it's much better to go around with a 4-legged walker and have no weight put into your armpit and get CRPS in your arms than to have your crutch and look like you're doing better. But if you're going to get a crutch, get this Moba crutch. They're available on Amazon. So here we have the wheelchair. And I have words to say about wheelchair. Wheelchairs sometimes are necessary, and here's where I thought some of you might have some offense to what I have to say. The best thing in a CRPS patient who hasn't been in a wheelchair is never to get in one. Now, if you're already in one, we can't change that, at least in the short term. Thing is, there are 2 things in my practice. I never give anybody permanent disability because I don't believe in it. I want everybody to have a chance at not being permanently disabled. And the other thing is I try to keep my patients out of wheelchairs, because once they go in wheelchairs, it's very hard to get them out, and that then you are disabled. And so if you already have a motorized wheelchair, then we could work to try to get you out of it, and I'm not going to try to take you, say you shouldn't be there. And sometimes people need wheelchairs when they go out for periods of time just so that they can go further. But to be in a wheelchair all the time does not help CRPS get better for sure. And again, if you already have one, we're in a different situation than if it's something you're considering. And so this is what I recommend, and I'm amazed. I saw one person with this exact one. The idea here, if you're going out, you need support. Sometimes you need to sit down. You can sit down on this and you can move yourself around some with the wheels. It has brakes. I don't like the kind that have the flat back so that, I mean, it's that sound that, I don't know how many of you heard it. It's when the people don't put tennis balls on the back, two parts of it. And the ones with wheels are better. And if you notice, this one has hand brakes. So it also has a seat and it has a place to store stuff when you go out. This is what I urge people who have problems with mobility to get, because we really want you to get out. We want you to do things. We don't want you to be so encumbered that going out becomes too big a deal. And so here, this is the compromise. And what I can tell you is that of my patients that I convinced to use this rather than a wheelchair, we haven't had to go to wheelchair. Because once you go to wheelchair, you're using your limb less. Use it or lose it. The less you use it, the worse it gets. You got to use it or lose it. And Dr. Sadiq said it, and anybody who knows this disease knows it's true. Okay, some words about surgery. Well, number one, if surgery is elective, don't do it. I mean, elective means you don't have to do it. So I have vain young women. More than half my practice are women 20 to 40, and that is the demographic on CRPS. Vanity will say, well, maybe I should get a facelift, maybe I should get a tummy tuck. And the answer is absolutely not. And one of my patients now, about 3 months later, is very happy that I introduced her, because I stay up late at night and watch TV in the middle of the night with these horrible infomercials, crepe erase. So she had wrinkles and she wanted to get a facelift. And we've seen what happens to CRPS and people that get facelifts, even if the CRPS wasn't up there. And there's a lot of work that's done on a facelift, and it can really flame the CRPS. So this woman's using crepe erase now. She rubs it on her skin. That step one, and then step two, some cream. So first you rub out the wrinkles, then you fill them in with cream. She looks great. And my nurse was laughing with me the other day how I've made her a believer, and I should go on the infomercials for crepe erase. But there are all kinds of different elective surgeries, and I would actually put tattoos in that category. If you already have a tattoo, you have a tattoo. To do tattoos to somebody that has CRPS and create that kind of pain is just not a good idea. So the basic punchline of this story is anything that's elective should not be done. But unfortunately, there are surgeries that are necessary. And one of the principles of treating CRPS is that if there's an underlying process that is inflaming the CRPS, such as when, let's say I get CRPS under control, but there's a malunion in the foot that even when the CRPS is under control in the leg, the malunion feeds the CRPS, and the CRPS comes back even when it's been in remission. Doing it over and over again doesn't make that any better. You have to take care of this inflammatory process in the foot. So if you have to have it done, you have to have it done. And that's a principle of our care. So what do you do? Well, the first thing is you got to get the surgeon on board with your pain doctor, with your anesthesiologist. Communication. I say that's a novel concept in my practice in the year 2019. We communicate. I don't only communicate with my whole team, and it's a big team of physical therapists, psychologists, massage, acupuncture, chiropractic, nutrition. We communicate with each other, but very important that I communicate with your surgeon before you have the surgery so that they know what needs to be done. And if you're having foot surgery, the best thing to do is to have an epidural put down on the side where the surgery is going to be done, with the tip right by the nerve roots that go to the feet, so that they can give you surgical level anesthesia with that epidural, so that, as Dr. Sadiq was saying, the nervous system is what is disturbed in this syndrome. And if you send it surgery information, which is very painful information, whether you're under general anesthesia or not, the cord is getting it, and it's even getting to the brain, you're just asleep, That feeds the CRPS. So we want to block it out so that the cord never gets the information from the surgery. So we put a catheter in to just block it out. And we want the anesthesiologist, whether they want to put the patient to sleep or not for the case, to make sure before the surgery starts that they actually can provide surgical anesthesia with their epidural so that they could put a clamp on the area where they're operating before they operate and the patient does not feel it. So that's part one, is a block that prevents the cord from getting the information. Part two is having it be a continuous block so that the next day the catheter can still run for a day or two, so during the post-operative period the patient is not experiencing that pain. Very high patient satisfaction with that, because the worst time after surgery, that pain time doesn't happen. But that has to be coordinated and can't be done in an outpatient surgery center because the patient has to stay at least 24 hours. I mean, it can be if it's just 24 and they leave the next day. There's a device called an on-cue, which is, it looks like a little rubber hand grenade, plastic hand grenade, and it has medicine in it that can feed the catheter. So some patients can go home and they can squeeze the medicine into the catheter so they don't have to stay beyond overnight. But we want these patients always to stay until the next morning. So we've covered two pieces now. Number one, the right kind of block. Number two, the continuity till the next day. There's a new medicine out called Exparel, which they can put in the wound. It's a kind of local anesthetic that lasts 72 hours because it's in microspheres. And so that's really helpful. Most insurance companies, unfortunately, even though it probably would save them money, they don't pay for Exparel. And the advantage of Exparel is to have 72 hours of local anesthesia from wherever they're putting in local anesthesia, rather than just 4 or 5 hours. The thing is, most surgery centers now, even if the insurance isn't covering it, will sell it to you at cost. It's a few $100s, and I think it's worth every penny of it. So, continuity of the block, having a block, and number three is prophylactic medications. And we go overboard on this. If you were on Lyrica, you're on Neurontin, gabapentin, or you're on Cymbalta, whatever you were on, we put you on it for 3 or 4 days at high dose, and I don't care if you aren't yourself during those 3 or 4 days and you can't do calculations or remember what you went to the refrigerator for. It's really not that important during those 3 days. The important thing is that we keep the central nervous system from getting resensitized from the surgery. So we start 24 hours before and we go till 48 hours after. It's 3 days, and believe me, it makes a very big difference. The other thing that I didn't throw in here is vitamin C, whenever they do orthopedic work, has been proven to actually minimize the impact of bone problem on CRPS. So that's really the piece. There are 3 pieces to it, and really, truly, the key is communication of the whole team with each other. Well, along these same lines is childbirth, because childbirth is a trauma, and any trauma can bring on CRPS in a new place, and the last place you want to have CRPS is in your vagina. And again, like 80% of my patients are women between 20 and 40. That means they're in childbearing years. And one of the biggest prides I have in my practice is my album of babies to mothers who had CRPS before they had their baby, that we got them to the point where they could get into a relationship, get married, have children, and be a mother. And to me, that's one of the things I'm most proud of in my practice, is this album. But there are elements to this. One is if they have to do a forceps delivery or any kind of trauma or episiotomy, then you're having significant trauma done in that area that then if you get CRPS there, you can never have sex again. So we recommend to do a C-section electively. They can use local anesthetic in the skin. CRPS tends to be worse where there are more pain receptors in the first place. The abdominal wall basically barely has any. When you think about yourself, you pinch yourself there, compare that to pinching your tongue, and you see what the receptor, how different it is. So we recommend a continuous either spinal or epidural for 24 to 48 hours after, that the epidural be done again at surgical level before they ever start the C-section. What I can tell you now, having recommended this and done the protocol for better than 20 years, is that 100% of the patients who have followed this protocol, whose anesthesiologist followed the protocol, have not had any CRPS as a result of delivering a baby. I have had one doctor actually from an anesthesiologist from this county who was afraid to do what I recommended, and that patient, they did do a C-section, but she wound up with CRPS in her abdominal wall, but it's not a really bad CRPS, and nonetheless, it didn't used to be there, and now it's there. So, vaginal delivery is a trauma. You want to prevent the trauma any way you can, and so a C-section is controlled. They can put plenty of local anesthetic in the skin. They know what they're doing ahead of time. And as I said, I have a whole album of babies born with C-sections where the mothers don't have any CRPS as a result of the delivery. And just an interesting thing is, probably 9 times out of 10, CRPS gets better during pregnancy. Sometimes it doesn't come back as much. Sometimes it does. But it makes pregnancy much more bearable when, whatever reason, the hormones do whatever they do, and you get through pregnancy. And I think being a mom is great for somebody who has CRPS. Even if you have to struggle with the CRPS afterwards, you're in a loving relationship in a different way than having a caregiver for you. So along these lines, what happens if you have CRPS, it's in remission or it's not in remission, you get in a motor vehicle accident, you fall down, and it's amazing how common it is for CRPS patients to get in motor vehicle accidents. And I haven't completely figured that one out, but we see a lot of people getting hit from behind, more than in the general population. You hit your shoulder when you had CRPS in your leg, you're going to get CRPS in your shoulder unless you do something. So what do? Same thing, high-dose medicines for a short time. Usually a nerve block is a really good thing to do. Don't baby it too much. Make sure whatever is going on there is diagnosed and treated. We have a really good track record when my patients come in. The one thing I left out on surgery is dental surgery. I mentioned plastic surgery. Well, plastic surgery in the face is elective. Dental surgery, like a tooth extraction, is not, and we have a whole prophylactic regimen for that. It includes communicating with the dentist. If it's just a simple filling, we find it doesn't matter, although we always ask that the dentist provide the maximum amount of local anesthetic in whatever they're doing. So the question is, if you have a new trauma, should you get ketamine? And what our experience is that when CRPS is spreading, that's a place where ketamine really, really works, and quickly. And so a little bit of ketamine, and it's not a whole course of ketamine, but just a little bit of ketamine to prevent the spread is a good thing. And that could mean 1 to 3 sessions, not a full course. So here's one that nobody's ever heard about, which is flying altitude, low oxygen. I've had now 3 patients move to Denver, and all 3 moved back to LA because low oxygen in the mild high city makes CRPS worse. And flying long flights makes CRPS worse. I have a patient who has 2 daughters, twins at Boston College, and he would find that he would fly there, 6-hour, 5-hour flight, and get off the plane. He couldn't go very easily to Boston College to see his daughters. The low oxygen for sustained periods of time makes CRPS worse. And I'll get to the solution in a second, but what I can tell you is that there are many case reports in the literature, and one of them was mine, demonstrating the efficacy of hyperbaric oxygen in treating CRPS. No controlled studies been done, but if high oxygen will make CRPS better, it kind of is common sense that low oxygen can make it worse. And certainly, I have a number of patients who don't go on long flights, anymore without what I'm about to tell you about. And this is a device, and I don't own stock in this company either, but this is called an Inogen. And what an Inogen does is it takes oxygen out of the air, concentrates it so you can get oxygen in nasal prongs in your nose. And I first saw this I was always thinking, what could I do? I'd have some patients carry these big green oxygen tanks on the plane. It's a big pain to get them on the plane. You have to get them refilled when you get off the plane. And this guy is sitting there with his COPD next to me on the plane. He sounded like a COPD guy. But he had this gadget, and I said, what's that? And he said, well, it's my Inogen. Now I can fly. I couldn't fly. There was too little oxygen on the plane, but now I can fly. This one is 2.8 pounds. It has a battery. It lasts for 2.7 hours. With the double battery, it lasts for 5 hours. What I found in putting this slide together for this talk, again, I never gave this talk before, is that the Inogen is not the only one that makes these now. There's one made by Puritan Bennett, and there are a few out on the market. The point is that this is something that's rechargeable, that comes with batteries, that is FAA compliant, so you can go through the TSA without a problem, that if you're going to fly fly to San Francisco, probably doesn't matter. It's 40 minutes of low oxygen. But if you're flying to New York or you're flying to Europe, this is truly what makes sense for you, even if you have to buy 2 more extra batteries. The batteries come in and out. But don't move to Denver. Don't spend a lot of time up at Pikes Peak. And if you're flying for more than an hour or 2, then consider getting one of these. Now, a few of my patients on lower budgets who don't fly very much have bought this. You get 30-day, no questions return. So that you get one free use that way. So I'm going to talk a little bit more again, following on what Dr. Sadiq was talking about, choosing a CRPS provider. And one of the ways, certainly, if you know people who have CRPS, that's a good way to find out if you have somebody good. But so you join a support group like CRPS Forum, but you're all here. So pick the brain of people around you if you don't have the doctor that you want. It's important that the doctor really understands CRPS, and unfortunately, neurologists, orthopedists, podiatrists, I've met one podiatrist that really has a good understanding of CRPS, and he's in Seattle, and we lecture together. Doctor has to really know CRPS, but the next thing is this guy a one-trick pony? I do lumbar sympathetic blocks, and that's what I do. That's what you're going to get. That's what I know how to do. Or I give Neurontin, I give Lyrica, and that's what I do. Well, CRPS, and I'm going to give Dr. Stanton Hicks's talk this afternoon, which is a more academic kind of talk. The best way to approach CRPS is with multimodality. Physical therapy should be the mainstay. Now, in order to do physical therapy, sometimes you need a method of pain relief. And I'll just talk about the 2 kinds of mistakes that physical therapists make. And I label them 1 and 2. They're my own labeling system. Type 1, you go after the patient so hard, patient's never going to set foot in that office again. Type 2, so afraid of type 1, you never accomplish anything because you don't do anything. And you need a physical therapist that works regularly with CRPS patients to understand that it's start low, go slow. Get the patient used to what you're doing, build trust, build communication, and then gently progress even to the point where you can then use a scrub brush on your foot, which you never would do at the beginning. You don't start sticking your foot in rice on day 1 when you have flaming allodynia in your foot. It's just, you'll run out of there even though you can't walk. So it's not only the doctor, but the doctor has to have resources, psychologists that know what CRPS is, that know, again, what Dr. Sadiq was talking about. The brain changes with CRPS. When you get depressed, it's not, oh, I'm depressed because I have pain. It's no, I'm depressed because my brain changed. And the part of the brain that Dr. Steek was talking about, the limbic system, actually, if you look at a functional MRI, you will see that blood flow changes in parts of the brain related to behavior, depression, insomnia, appetite, motivation, and most importantly, suffering. Suffering different than the sensation of pain. Suffering is what you experience. Anybody can have a pain. I stub my toe, I have a pain. I'm not suffering, it just hurts. You have CRPS, you are suffering. It's an experience. And that is a change in the brain. And you have to have a psychologist that doesn't just think, oh, this person's crazy and that's part of their pain. Which kind of gets me to, well, no, that's in my next slide, sorry. But the other thing you want to find out from your doctor before you go there is what kind of insurance they take to make sure that it fits with what your scheme is, because the last thing is to get hope and then find out that the doctor is not on your insurance plan. It's not an unreasonable thing to ask the doctor if one of their patients will call you and kind of talk about what the experience is. Because I think you get the best feel of this whole thing from somebody. I try to demographically match patients. You know, so if you're a 40-year-old female, I try to get you a 40-year-old female. Or somebody in a similar age group, similar sex, so that you can relate a little bit better. But if the doctor doesn't have a patient you can talk to, that's kind of a funny thing. Now, you don't ask, can I have the patient's number? But you say, can the patient call me? And the patient can call you from a block number. Who cares? They're calling you. They're not going to be bugging you going forward. So this is like a really important one. I don't know how many of you have encountered this, but if the doctor tells you that all this is in your head, get the hell out of there. It's true. And I mean, clearly by the reaction, we know it's true, and I have goosebumps with the reaction. But the average patient who comes to see me has seen 6 pain doctors before they get there, and half of them have said, oh, well, if you just think positively, it's all going to get better. Oh, yeah, well, you're just amplifying it. It is real. And a doctor that doesn't understand it's real and denies it is not somebody you want caring for you. Choosing a ketamine provider, and ketamine can be very lucrative depending on how it's done, especially if you cut corners and you're not doing it in a high quality facility, you're not doing it with ICU quality nurses, but you're using a medical assistant, which I know places that do. In choosing a ketamine provider, these are the things that you want to ask. What kind of experience do they have doing it? How long have they been doing it? If who's ever doing the ketamine, if they have other modalities available in their practice, or if that's the only thing they do. Now, I can't tell you how many patients come to me because I have a name in ketamine. Patients come to me and they say, I want ketamine. And I say, well, have you tried Cymbalta? No. Well, maybe we should try Cymbalta before we try ketamine. Ketamine's expensive. The risks, when done properly, are extremely low. Nonetheless, there are risks involved with it. But somebody who only offers one modality, it's kind of like the world is a bunch of nails and I have a hammer in my hand, and everything that comes in, everybody's getting ketamine, whether it's the right thing or not. And ketamine isn't, it should be somewhere low down in the treatment algorithm, not right at the beginning. And so guys who, there's one guy in LA, he's on TV, he goes advertising, he spends a lot of money on Google AdWords, and he does ketamine. So the next thing is, what kind of evaluation do you get? If it's a psychiatric patient, has a psychiatrist recommended the ketamine for depression, or is it just something you're thinking about yourself and you don't really have a qualified psychiatrist to say it's the right thing to do? You want to know if you're medically safe for the ketamine, and an evaluation should be done in that fashion before you engage in a serious medical procedure. That should be done in a highly monitored setting with nurses who can manage a patient in an ICU or at the minimum in an emergency room. You want to know a little bit about the dosage ranges that they charge and also how much they charge for them, because there are ones that charge low, but they never give you much dose. A lot of my patients have gone up to Grass Valley, because there's a guy up the Grass Valley is near Sacramento who's very cheap, but he never goes over 200. And so they come back very unhappy, and he also doesn't give anything to prevent the hallucinations. And that makes it a really unpleasant experience. Now, here's a really important one, because there are guys who were practicing anesthesia and kind of lost hospital privileges to give anesthesia and now reinvent themselves at an old age to give ketamine. If you're thinking about using anybody, go to the medical board, California medicalboard.gov, ca.gov, and look up the doctor's name and look at public enforcement documents and see things like you can find very easily loss of hospital privileges, cited and suspended license for gross negligence, cited and lost license or suspended license for clinical incompetence. I mean, these are there. There's a website, I think it's called Ketamine Resource, the Ketamine Resource site or something like that, that is actually looking at doctors around the country, and they don't recommend any doctors. That's not what they're there for. They just list by state. They tell you the specialty, the setting, and they list the enforcement documents for the physician. So you can, I think it's called a ketamine resource. I'm not sure the name of it. You want to know, again, what the setting is where the ketamine is being administered and who is doing the monitoring and how many patients that person is monitoring at one time. So ketamine, it's something I believe in. I believe in it for CRPS. Purpose of today's talk is not to talk about ketamine, but just talk kind of some wisdom for you guys that if you're thinking, well, maybe my doctor's a good CRPS doc, but he doesn't give ketamine, or she doesn't give ketamine, maybe I should go get ketamine. Do your own due diligence before you go there, or you can buy yourself a pack of trouble and possibly waste money. So, we're here at the CRPS Forum. It's so great to see all you warriors here to learn, to support each other, and for Roxanne to be you call me the whisperer, I call you the wizard. Roxanne is really selfless in what she's doing. Thank you for the privilege of being able to speak to all of you, and I'm available for questions. Thanks.